We'll have a lecture by Dr. Chari, followed by two interesting case discussions. That should be the end of it. Common clinical scenario, how to manage,
Okay.
Okay, I think I see the explanation. Whoops. Okay. Okay. So Dr. H. Ramesh is also here. I think I've just added him as a panelist, so that should do it. Great. It's quite nice. I mean, I was expecting less, but we do have a lot of people who have registered. So
it's a great number, actually. 100 participants on a Sunday evening is really great, I think.
No, it should cross 300, I'm sure.
Yeah. By that time
As
the
I
talks
think-
begins, it will start increasing.
Yeah. Sure.
I think in these days of COVID times, this should be done regularly. So, the education continues while we are stuck.
Yeah.
no, it's great just to review the literature, just to refresh. And after the pancreas clinic with you, good. Now I get a refresher again.
Yeah. Those days were great, like Dubai Hall.
Yeah.
Dubai Auditorium.
Yeah.
Just good to have weekly lectures on things and debates and discussions. There's so much.
The one who does it most consistently and religiously is Raju.
Yes.
Every Sunday morning he has a lecture, and he has panelists from all over the world.
Oh, that's
Wonderful.
great.
That's great.
Who Raju?
Raju?
G Raju with GS Raju. He's a PGI guy, 1 year junior to me.
Oh,
he's
where is he?
editor of GI video endoscopy.
Okay. Where is he?
He's at MD Anderson.
Oh, acha. That's too much of a consistency also. Hard work.
Hard work. Very hard.
Yeah.
So he sort of started the video GI. Is that?
Yeah. He's a founder editor.
Founder. Yeah, it's gained so much popularity. Actually, it's great for learning new techniques and what everybody's doing. It's just the right mode of understanding.
Whenever he talks, he has his fancy videos from all over the world. It's like
yeah. Oh, fantastic. All right, so I think it's 7:31. Maybe we can get through the introductions, and we'll probably have more people logging in, and that should be fine. If that's okay with everyone, we can.
Yeah.
Dr. Ramesh, I see you're a panelist. Could you please?
He needs to be unmasked panelist.
Yeah.
Hi.
Yeah, hi, Ramesh. Welcome.
Hello, sir.
How are you? Thank you. How are you all?
Fine.
Good.
Oh,
I didn't want to interrupt the cozy reminiscences of the Mayo Clinic and so on. Yeah.
Okay. So if okay with everyone, I'll just start the introductions and then we can get started. Okay. All right. So let's see. Okay. So we'll start the process. Hi, good evening, everyone. I'm Dr. Saurabh Mukhevar, and it's a great pleasure to have all of you here today. We have close to 170 people here, and it's increasing. So it's quite nice to see so many people turn up for an academic evening. These are tough times. And I thank all the chairpersons and Dr. Chari for sparing out time today evening from family days on Sunday. So thank you all. So we have Dr. Suresh Chari here, who is a world-renowned figure in pancreas diseases. And he is currently a professor at in Department of Gastroenterology at MD Anderson in Houston, Texas. He was a professor of medicine at Mayo Clinic from 2002 to 2019, where I had the privilege and honor to work with him closely as I was his mentee. For 1 whole year in the pancreas clinic, seeing patients with him day in, day out was a phenomenal experience, and it's nice to see him again today. So he was the director of Pancreas Fellowship there as well. He has several teaching awards while he was at the Mayo Clinic. He's been consistently funded by NIH for his research and has performed groundbreaking work in pancreatic cancer and chronic pancreatitis. He has written over 300 peer-reviewed articles and several book chapters on pancreatic diseases. He's currently the editor-in-chief of the journal Pancreatology. He's co-authored the international guidelines for management of chronic pancreatitis. So he is the right person to give us a talk on chronic pancreatitis. Thank you, Dr. Chari, for joining in today. And amongst the chairpersons, we have very highly illustrative chairpersons here, Dr. Amit Maideo, who is currently the chairman of Baldota Institute of Digestive Sciences at Global Hospital in Mumbai. He needs no introduction. I think everybody related to gastroenterology knows Dr. Maideo. His main research interest is in the field of GI endoscopy, particularly interventional ERCP, and now he's leading the third space endoscopy effort in India. He's published over 200 papers in national and international peer-reviewed journals, written more than 7 textbook chapters. He's on the international editorial board for GI endoscopy, as well as a co-editor for the Endoscopy International Open Journal. He's been visiting faculty for numerous endoscopy workshops and conducted 21 international live endoscopy workshops in Mumbai. He also has an endoscopy training institute known as the Endoscopy Gurukul. He's also been awarded the Padma Shri in 2013 for his outstanding contribution. And with his vast experience with endotherapy for chronic pancreatitis, we look forward to his comments today. So thank you, Dr. Maideo. Next, we have Dr. Roopjyoti Talukdar, who is the Director of Pancreatology at Asian Institute of Gastroenterology in Hyderabad. He did his MD from Guwahati Medical College and residency in PSRI in New Delhi, and was a former pancreas fellow at the Mayo Clinic with Dr. Chari. He's an associate editor for Digestive Disease and Sciences and BMC Gastroenterology. He's the editorial board member for Pancreatology and Indian Journal of Gastroenterology. He's, in a short span of time, had over 100 full-length scientific publications with several international and national conference presentations. So Roop has done a lot of important work in chronic pancreatitis, and I'm glad that he could join us today to have a more unbiased, non-surgical, non-endoscopic clinical pancreatology opinion. So thank you, Roop.
Thank you.
And then we have Dr. H. Ramesh, who's been very modest that he's had more than 30 years of experience in GI surgery. He's at the Lakeshore Hospital in Kochi. He's served in several key positions in GI surgery and digestive disease centers in Kerala. He's a fellow of American College of Surgeons and fellow of the Royal College of Surgeons in England. He's received several awards and has over 130 papers, and has a specific research focus in surgical management of chronic pancreatitis. So thank you, Dr. H. Ramesh, for joining in today. We look forward to your comments as we discuss some cases today. Thank you so much. And I will hand over the proceedings to Dr. Chari to start his talk. Thank you.
Thank you, Saurabh, for this kind introduction, and very grateful for the opportunity to speak here, and amongst very distinguished panelists here. At the outset, I would like to express everybody's anguish at the COVID pandemic raging in India. It's raged everywhere. We had it in New York, we had it in Italy, we had it in a lot of places, but it just, heart goes out to the people who are struggling with this. So hopefully this too shall pass and we'll come out stronger. But it's also important that during this time that the education of those who are in training doesn't suffer. So this is a very great opportunity to continue that in some form or the other. And hopefully we will have a successful series of lectures on various topics. I was asked to speak on chronic pancreatitis, and sorry. Let me get this. Okay. This is not a it's a very broad topic, and I've tried to cover the entire topic, but we have experts in in various areas of the disease management, and hopefully we'll have a fruitful discussion afterwards based on case-based discussions. But one thing I wanted to introduce was a term you might not have heard, which is the chronic inflammatory disease of the pancreas. Seems very simple. It is self-explanatory term, which means that it's chronic, it's fibroinflammatory, and it's a disease of the pancreas. So why introduce this new term? So when I think of chronic pancreatitis, and probably this is how everybody thinks of chronic pancreatitis, it's defined by its characteristic clinical features of severe abdominal pain with and without bouts of pancreatitis, pancreatic ductal calcification, strictures, dilatation, glandular atrophy, leading to exudative and endocrine pancreatic insufficiency. And you would say, yeah, of course, that is CP. So this clinical profile best describes patients with classic CP due to alcohol, smoking, and certain gene mutations. Of course, many idiopathic pancreatitis, where we don't know yet what's going on, often fit this profile of acute, recurrent acute, going on to chronic. What I mean by chronic inflammatory disease of the pancreas is generally refers to diseases that we often use CP, but with a qualifier, because they share features which are common with classic CP. The end stages of all these diseases look alike, but some have very different etiologies, pathogenesis, treatment, and in some cases histopathology. Analogy would be, imagine if all IBDs were referred to as chronic colitis. That would be very confusing. And we would have Crohn's disease as a type of chronic colitis and ulcerative colitis. So anyway, because of this thing, I thought we should step back and try to look at the chronic diseases of the pancreas the same way. So if you look at the various CIPDs, you'll see that it's classic CP, which is alcohol, smoking, genetic, and the subject of today's talk. I won't cover these other entities. They do come with a qualifier like obstructive CP. This occurs due to tumors, traumatic strictures, and anastomotic strictures, and they usually do not calcify. And most don't get acute pancreatitis. And relief of obstruction, if symptomatic, is the treatment. Many of them are asymptomatic and don't have to do anything, but if they are symptomatic, then relief of the obstruction or removal of the upstream part of the gland relieves the problem. Then there is a couple of diseases that are steroid responsive, and we know them to be as AIP type 1 and type 2, which again I have a problem with because these are two different diseases. And they have a very unique treatment. Both of them have different treatments, and the histopathology is very distinct. So essentially they're two different diseases, but they're both steroid responsive. But to call them chronic pancreatitis makes no sense because they have nothing in common with alcoholic pancreatitis, for example. Similarly, this metabolic CP, distinct etiology, potentially can prevent progression by removing the metabolic insult. Same thing with hypercalcemia. And then there's a group of people who develop advanced calcification, diabetes, and steatorrhea, and have never had an attack of pancreatitis in the past. I'm not sure what this is. This probably is a different disease, but certainly doesn't fit the profile of what we were described earlier as classic chronic pancreatitis. So here's a question related to this. You don't have to answer this, but just think through this. The 45-year-old male drinks 2 to 3 glasses of wine a day for 20 years, half pack of cigarettes for 20 years, was sent to you for dilated pancreatic duct with abrupt cutoff in the body of the pancreas. He had never had pain, never had pancreatitis. An endoscopic ultrasound showed an islet cell tumor at the site of the duct cutoff. Normal head of the pancreas, normal neck of the pancreas, an atrophied tail of the pancreas with changes of CP. His resection of the lesion confirms the diagnosis of islet cell tumor, and also shows all the changes that were seen on imaging, which is atrophy, marked fibrosis, and dilated duct in the distal pancreas with a normal head and neck of the pancreas. So the question is, what does this patient have? And the answers are, because of history of alcohol and smoking use, must be classic CP with incidental islet cell tumor, or because of islet cell tumor at the site of ductal obstruction must be obstructive chronic pancreatitis. Alcohol history is incidental, could be both, or due to absence of pain, patient has senile onset chronic pancreatitis. Now, I can give you the answer here, which is that the patient has obstructive chronic pancreatitis. And you might say, oh, of course, that is obvious. But from this, I want to illustrate the fact that these are distinct entities, and the patient has had the appropriate treatment for obstructive pancreatitis as well as for the tumor. And this is not something you would do for necessarily for alcoholic pancreatitis. So this is just to illustrate the point of the differences in these various entities that we're talking about, which are all clubbed together under one entity called chronic pancreatitis. So if you look at the classic natural history of classic chronic pancreatitis, this is what it's supposed to go through. Acute pancreatitis, recurrent acute pancreatitis leading to chronic inflammation, fibrosis, loss of acinar and islet cell mass, ductal distortion, calcification, which eventually leads to exocrine and endocrine failure. So this is a classic natural history of classic chronic pancreatitis. The stages that we are describing here of acute, recurrent acute, chronic, and fibrosis, as far as the chronic pancreatitis part of it is concerned, this is pre-diagnostic. That is, at this point, you can't make a diagnosis of chronic pancreatitis. This part where the CT findings start to appear and there is acinar loss, ductal distortion, calcification, I call established CP. And then there is this advanced CP where there's failure of the organ itself. So there are attempts being made to diagnose early CP, that is CT negative chronic pancreatitis, but it's still quite controversial and there's no diagnostic criteria for it. So at this point, we usually diagnose CP when it's already established, and of course, when it's advanced. So, but not all patients with CP progress to end-stage disease. But if you took a large cohort of subjects with CP, you would find the entire spectrum of the disease within that cohort. We don't fully understand the pathogenesis of each type of chronic pancreatitis. But in general, you'll see that the more, if you look at the gene environment and pancreatitis interplay, you'll see that the more there is an influence of genetic mutation, the more likely the patient gets pancreatitis. So there is this interplay. On one extreme, left extreme of, at least to my left, that's trauma. And if you get a blunt trauma to the middle of the abdomen, you don't care about the genetic makeup of the patient is going to get pancreatitis. So this is purely a physical issue. At the very extreme, you have PRSS1 mutation, and you don't care about alcohol or other history. This patient is going to have, there's an 85% chance this person is going to get pancreatitis because he has a mutation that predisposes that person to pancreatitis. Between these two extremes, where only one cause is needed, there's a whole bunch in the middle where there appears to be an interplay between the environment and genes, and the patient gets pancreatitis. But these pancreatitis episodes are different in the sense that from a standpoint of the patient, they are not passed on to the next generation. The presence of the mutation or the risk factor in the form of alcohol, for example, doesn't necessarily mean the patient has the disease. You have to take it in the right context, and the information has to be put together to understand whether the two are connected or not. But there's a broad interplay between genes, and environment in order to be able to cause pancreatitis in vast majority of patients. In the cationic trypsinogen gene, it is an autosomal dominant form with 80% penetrance. That's why I said that 80% of these patients are going to get pancreatitis. That's what that means. SPINK1 is 1 to 2% of normal people, and 20 to 40% of idiopathic pancreatitis will have SPINK1. In the variant that is seen in India, it's fairly high, as is seen in multiple centers in India. CFTR is found in 20 to 40% of idiopathic so-called sporadic pancreatitis. They're generally younger at onset. So if you have somebody at 25 and you don't know the cause, if you look at it, you might find it. though it may be less common in India. But these are and there are some, they keep adding to these lists of patients, and there are some even rarer ones as we go back, as we keep looking. So here what happens is there is premature intrapancreatic activation of trypsin. And this happens in everybody. As the machinery for generation of trypsin is generating trypsinogen, a small portion of trypsinogen gets activated to active trypsin within the acinar cell. In the normal process, this gets inactivated, and we'll see how. But if this continues without being stopped, there's intrapancreatic activation of other enzymes, as would happen in the intestines. Instead of that, it's happening in the pancreas. And this leads to pancreatic autodigestion and pancreatitis. Now, what is the protective mechanism against this? Because this appears to be a very powerful enzyme that is produced in the pancreas. Imagine all the food that you're eating, all the protein that you're eating is getting digested by the same trypsin. So technically, the pancreas has the capacity to digest itself. If you ate the pancreas, this is the same enzyme which is going to digest that pancreas. So there are some protective mechanisms within the pancreas that prevent it from getting digested. Of course, the first one is that trypsinogen is in a precursor form and needs to be converted to trypsin in order to be functioning. But what happens to the trypsin that gets activated within the pancreas? Well, there are two mechanisms by which it is prevented from causing harm. One is there is trypsin autolysis, and the second is that there is SPINK1, and both of them block the activation of trypsin and therefore prevent it from damaging the pancreas within the pancreas. And when you have a mutant trypsin that is resistant to autolysis, which is what happens in PRSS1, you have more enzymes available, active trypsin available, and their SPINK1 may not be effective because of the amount of PRSS1, but you can get pancreatitis. In SPINK1, it's the mutant SPINK1 that is ineffective, and if trypsin autolysis is also defective, then you can get pancreatitis. But there are at least 2 or 3 mechanisms to prevent the auto activation of pancreatic enzymes within the pancreas from destroying the pancreas. So when you move forward to how do you diagnose this condition of chronic pancreatitis, technically the definition is a histologic definition, but is frequently unavailable, if not mostly unavailable, until after surgery. So the diagnosis has to be made before surgery. And here one relies on clinical features and changes in structure and function. And this diagnosis is relatively easy in late stages, but difficult in the early stages of the disease. So the various tools we have for structural, to pick up the structural changes, these are abdominal X-ray, CT, ERCP, MRCP, EUS. We'll go through the pros and cons of these, but these are the tests for structural changes that we have. For the CT, the features of chronic pancreatitis on CT are calcification, dilated duct and parenchymal atrophy. Now, if you just look at those 3 features, I say they are the features of CP, but you will find that there are other conditions that can that also have this. For example, autoimmune pancreatitis later on can develop calcification, dilated duct and parenchymal atrophy. So it just is useful to understand that in the absence of any other cause, this suggests chronic pancreatitis. And it, of course, can pick up complications of chronic pancreatitis like bile duct obstruction, splenic vein thrombosis, pseudocysts, or inflammatory malignant masses. So CT is good for, overall, good for looking at the pancreas as well as any complications arising from the disease. You can see that if you use a non-contrast CT, you can pick up really small calcifications in the pancreas, which might otherwise be missed if you used contrast CT. This pancreas otherwise looks normal, looks nice and healthy, but has specks of calcification in it. In the advanced stages, you see all three features: dilated duct, atrophic pancreas, and calcification. So these are the various features of chronic pancreatitis on CT. But just like that normal pancreas I showed with a speck of calcification makes you wonder about chronic pancreatitis, what if that speck of calcification was not there? Can you still have chronic pancreatitis? Well, that is what I call CT negative chronic pancreatitis, or early CP. But currently, we don't have a definitely diagnosable way to diagnose those patients. So that's the holy grail of chronic pancreatitis, is to be able to detect chronic pancreatitis before advanced changes occur. And at this point, we can discuss the various criteria have been put forth, but they need to be tested. So what are the pros of CT scan? Expertise is widely available, detects early calcification. If you do a non-contrast CT, you can really see pinhead size calcifications. It's pretty good for even small calcification. And it's useful detecting complications and differential diagnosis of pain. It's not sensitive in early disease. And my overall assessment is that it's a good initial test for evaluating for possible CP and for sorting out the pain in CP. If you look at ERCP, I mean, I would right off the bat say that it should not be used for making a diagnosis, because there are other options for making a diagnosis. But if you were to have an ERCP in front of you, then the diagnosis is made by these Cambridge classification in mild chronic, at least by mild by Cambridge. There are more than 3 abnormal side branches with a normal main pancreatic duct. In moderate, the main itself is dilated and irregular. And in severe, there is a chain of lakes, calcification, and pseudocyst. The pros are that it's sensitive for moderate to severe disease and is widely available. But the cons are that there is risk of pancreatitis by just doing it. And early changes like the dilation of the side branches can be seen in elderly without having pancreatitis. But overall, due to risk of pancreatitis, it's not used to make a diagnosis, and used MRCP is used instead. Endoscopic ultrasound, obviously, Dr. Maydev is there, and he can talk more about this, but we look at changes in the parenchyma and changes in the pancreatic duct in order to make a diagnosis. And there are a number of criteria which are used, and there are cutoffs for how many criteria should be present. There appears to be still some requirements for understanding how to grade the severity of the changes, and does one strand make it one criterion, or should it be more diffuse? Regardless, most endosonographers have a good idea of when to make the call, but these are the changes are in the parenchyma as well as in the pancreatic duct, as is quite clear. This is a normal appearing pancreas with a salt and pepper appearance, and this is a patient with chronic pancreatitis with significant distortion of the pancreatic parenchyma and ducts. So this is what we are looking for in chronic pancreatitis. The pros of this are the high resolution images and changes noted before other imaging studies. So oftentimes that patient with a chronic, with a normal looking CT, if the patient truly has chronic pancreatitis and you do an endoscopic ultrasound, that endoscopic ultrasound should be abnormal. I'm not aware of chronic pancreatitis that has a normal EUS. I don't know how I would make that diagnosis. Cons, expertise is not widely available, is operator dependent, diagnostic criteria not agreed upon, and false positive changes can occur with age, alcohol, and acute pancreatitis, and a number of other conditions. So often used to make the diagnosis, but should be interpreted with caution without patient context. If you see calcifications, of course, that's a different matter, but many of the other changes are not specific. So you want to make that in the context of the patient's history rather than independently make the diagnosis on that. So while it's very helpful, it also has to be used with caution. The MRI, MRCP, the pros are that it's non-invasive, and I say no need for sedation, but some patients are very restless or claustrophobic and need sedation. There's no need for radiation and avoids the risk of ERCP. Small duct changes and calcifications are not readily detectable. And of course, it has no therapeutic potential. It's overall, I think it's a very useful technique for detecting chronic pancreatitis as early as we can. One note of caution here is that even in 30% of normal people, if you do an MRCP, portions of the pancreatic duct are not visible on the MRCP. This should not be taken as a sign of stricturing, especially when there is no post-stricture dilatation of the pancreatic duct. So that is one caveat that can be fairly significant. I just saw a case presentation the other day where MRCP is used both to diagnose AIP and for resolution of the stricture. And I'm not sure that is necessarily true, and that it's just is a technique issue. So that has to be taken into account. MRCP. What about pancreatic function tests? So obviously there is invasive tests of pancreatic function like secretin and CCK, which are largely unavailable, and then non-invasive tests like fecal fat, fecal elastase, and fecal chymotrypsin. At least in the United States, the direct pancreatic function tests with secretin and CCK are rarely, if ever, performed. CCK for sure is not performed, and secretin and maybe in some centers. Most people rely on fecal elastase, not even fecal fat, and I don't necessarily agree with that, but it's basically down to non-invasive testing. So what are the pros and cons of doing pancreatic function testing? It's evidence of pancreatic exocrine deficiency, and it's a test of acinar function, useful in differential diagnosis of steatorrhea. Exocrine deficiency is not specific for CP. So if you look at fecal elastase especially, you'll see that 25% of type 1 diabetes has an abnormal fecal elastase, and 40% of type 1 and 25% of type 2. And similarly, there are a number of other diseases where fecal elastase is abnormal. So an exocrine abnormal fecal elastase or exocrine deficiency is not equal to chronic pancreatitis and is not a signal to use pancreatic enzymes there. Unfortunately, the invasive tests are not widely available, and the non-invasive tests are poor sensitive for early disease. So overall limited role for non-invasive testing in this setting. I use fecal fat a lot, but again, that's only in advanced disease that would be positive. So as I said, I'm covering a lot of topics and there'll be a lot of questions, so I'm happy to answer them later on. There are panelists who have expertise in various areas and they will chip in as well. But there's a lot to be covered here, and it cannot potentially cover every single question that's coming up in your mind. The natural history of chronic pancreatitis can be divided into early and late. In the early stages, there's clinically recurrent acute pancreatitis and the complications of acute pancreatitis. In later stages, there's complications of fibrosis of gland and progressive exocrine and endocrine insufficiency. So fairly straightforward. The complications of chronic pancreatitis include pseudocyst, bile duct obstruction, portal hypertension, diabetes, steatorrhea, pancreatic cancer. I'll go through some of these, and then I think the pain is the biggest issue, and I'll cover that at the end. A 40-year-old alcoholic male was discharged 2 months ago after 2-week hospitalization for clinically acute pancreatitis. He returned with nausea, vomiting, and abdominal pain. On examination, he's afebrile and no acute distress. An abdominal exam reveals tenderness in the right upper quadrant. You will notice that I use the term clinically acute pancreatitis, and I am very sensitive to the use of the term acute pancreatitis when the patient has underlying chronic pancreatitis, because I think the two terms should be used in the way they should be used. And here, what we are describing is a acute pancreatitis that is clinically diagnosed with enzyme elevation and whatever else. So that's why I call it clinically acute pancreatitis. But anyway, this patient had, this is the CT is the answer here. So this is what the CT shows. So the question is, what should be done for this patient? This is the ERCP. So percutaneous aspiration of the pseudocyst, total parenteral nutrition observed, endoscopic or surgical cyst gastrostomy, place nasal tube, start tube feeds, and repeat scan in 4 weeks. I think the answer is very clear. It's endoscopic or surgical cyst gastrostomy, but the teaching here is that the pseudocyst management depends on maturity of cyst wall, symptoms, associated ductal stricture. Small asymptomatic cysts may be clinically followed. ERCP needed before treatment in terms of understanding the ductal disruption and stricturing. Cyst gastrostomy if no associated ductal stricture, and surgical resection of downstream strictures. Again, there are ways of managing these patients without needing surgical resection. And so these are not written in stone, these are just guidelines. So if one drains the cyst and on follow-up finds as a stricture, then that can be addressed. If on follow-up one finds a leak, that can be addressed. So yes, endoscopic treatment can pretty much take care of these patients without need for surgery, but the surgery may be needed in a small subset of patients. But the smaller cysts which are asymptomatic may be clinically followed. Diabetes is due to decrease in beta cell mass, uncommon at diagnosis. At least in classic CP, 85% will eventually develop it, and surgery does not alter the incidence and severity of this. I've been sent patients from across the country who have painless chronic pancreatitis, but have been sent to me for possible intervention because they think that diabetes can be prevented from happening. There's only one guideline, I think the Italian guideline, which says to discuss with the patient the uncertainty of the outcomes for endocrine function alone. I would agree that for the most part, the effort needed to clear this duct of stones or to open up strictures and the possible benefit of reducing diabetes or reducing the burden of diabetes is in favor of not doing anything rather than going and treating patients who are asymptomatic. So I don't offer intervention for patients who are asymptomatic and want their diabetes improved. Steatorrhea occurs when more than 90% of pancreatic exocrine function is lost, and the treatment is enzyme replacement. There are both non-enteric coated and enteric coated enzymes. Acid reduction is useful, especially in the non-enteric coated type. Again, I could give a whole hour lecture on pancreatic function and how to treat it and how to diagnose it. So if there are questions, I'm happy to take them afterwards. Portal hypertension due to splenic, portal, and mesenteric vein thrombosis may be symptomatic or present with recurrent bleeding, maybe asymptomatic or present with recurrent bleeding. Splenic vein thrombosis is also known as sinistral portal hypertension or left-sided portal hypertension with splenomegaly and gastric varices. If they're symptomatic, then a splenectomy will take care of it, and oftentimes that's what is needed. There's portal vein thrombosis with large number of collaterals in the portal tract. Bile duct obstruction has a differential. In the early stages, it could be edema of the head of the pancreas. In later stages, it could be fibrotic, the fibrosis just engulfing the head of the bile duct and causing stricture. And of course, later in the course of disease, especially if the patient has been painless for a while and now starts having pain, one has to seriously consider a possibility that there is a malignancy underlying the stricture. And the cancer complicates all forms of chronic pancreatitis. Risk factors are basically duration of disease and smoking. People often done genetic testing in young people, but the genetic test itself does not tell you the predisposition to cancer. It just is referring to a disease that's been present for a long time. It's a surrogate for duration of disease. And tropical pancreatitis, or the pancreatitis occurring in southern India or in parts of idiopathic pancreatitis occurring in parts of India that occurs very early, is just at higher risk of getting cancer as any in the West. There's poor prognosis and there's no good screening tests. So it's a very devastating complication of the disease. So here's another question. 44-year-old male, alcoholic male, recurrent bouts of intractable abdominal pain associated with elevated enzymes. Attacks occur every 3 to 4 months and require hospitalization for 7 to 10 days each. Between attacks, patient has pain 2 to 3 days a week. Diabetes diagnosed 6 months ago. He's already on narcotics and unable to return to work due to frequent hospitalizations. So this is the most intractable and difficult management problem in chronic pancreatitis, and that is pain. This is that patient's CT showing calcifications in the head and a dilated duct in the body and tail. An ERCP showing at least 7-millimeter duct. So what is the most appropriate intervention here? ESWL with removal of stones, lateral pancreatic jejunostomy, distal pancreatectomy, bowel rest, and total parenteral nutrition, and total pancreatectomy and islet cell transplantation. We have panelists that can very well discuss this question, so we'll wait to hear what they have to say, but pain is the most difficult problem to deal with in chronic pancreatitis. If it was painless, we would be far less interested in chronic pancreatitis. So one has to assess the pain pattern, intermittent or continuous, frequency, intensity, tendency to use narcotics, effects on quality of life, and try to be conservative if the pain is non-disruptive and infrequent, and intervene only when absolutely necessary, because none of our techniques are perfect. Non-surgical approaches are, there are 3 different approaches overall: non-surgical, endoscopic, and surgical approaches. The non-surgical approaches are all pretty non-medical approaches are not very effective. That includes pancreatic enzymes and use of pain medication. Endoscopic therapy with sphincterotomy, lithotripsy, and pancreatic duct stenting. And some people have tried celiac plexus blocks, but it doesn't really work. So for small duct disease, resection in the most affected portion of the pancreas, these are the surgical options. In the large duct disease, drainage procedures like lateral pancreatic jejunostomy would be an option. But then there are many variations, including coring of the head and drainage procedure combined, like the Fry procedure or the Bager procedure, where you just core out the head. And so there are a number of variations of the surgical procedure itself, attempting to maintain a large portion of the pancreas if possible. So this is a classic Whipple that is done in, at least in Mayo, that used to be a common surgical approach to painful chronic pancreatitis with predominantly disease in the head of the pancreas. There's a duodenum preserving head resection, which is the Bager procedure. But if the same duct was also markedly dilated, then the coring would be less aggressive, and there would be an extension of the into the ducts, and there would also be a pancreatitis associated with a smaller coring of the head to relieve the bile duct. So that's the Fry procedure. And then there is a classic, complete opening up of the whole pancreatic duct and doing a Pustow procedure. As I had mentioned before, many of these subtopics are entire lectures in themselves, and I think if questions arise, we can discuss these with the panelists. So in summary, classic chronic pancreatitis, alcohol is the most common cause. So genetic obviously is another important cause, and then there is idiopathic. So progressive disorder, diagnosis is difficult to make before obvious structural changes occur. Complications affect the pancreas and neighboring vessels and organs. And the pain is the most difficult treatment problem. And surgery is in select patients. I did not cover total pancreatectomy. I know some centers are offering it, but we can discuss that as to what the role of that would be in the management of chronic pancreatitis. I'll stop here and go ahead with how you want to handle the rest of the program. Thanks.
Okay, great. Thank you. Thank you so much, Dr. Chari. That was a fairly large topic, and you've tried your best to cover it very nicely, the whole of it. So we do have question and answers. What we could do is probably maybe I shoot a couple of questions, then we'll go through one case, and then some things are part of the case. So I would probably reserve those Q&As during the case discussion itself. So there've been a couple of questions about the role of EUS in pancreatic cancer screening in patients with chronic pancreatitis. Now, Dr. Chari, Dr. Maideo, Roop, I know you've asked this, but I think that this is really not well defined. And I think what we have, it's hard to, on the basis of imaging appearance of EUS, determine if it's cancer or not. Dr. Maideo, at your center, what's been your experience like?
Yeah, if there is one condition where the EUS is very low sensitivity in picking up a malignancy, and that is in the setting of chronic pancreatitis. So EUS, I don't think is the ideal investigation to try to pick up a malignancy in the setting of chronic pancreatitis, because it's very difficult to diagnose a specific hypoechoic lesion in a chronic pancreatitis tissue. So probably a CT scan, a properly done CT scan will become a better diagnosis than a EUS. So nowadays we don't do EUS, even if you're suspecting a pancreatic cancer, we do it, but very, very rarely we can pick it up with surety.
Right. And I think the properly done scan in terms of doing it a pancreas protocol, which is, Dr. Chari, that was something you emphasized while at Mayo, to have it done the right way, and the right way the contrast has to be given, as opposed to not getting, doing the regular IV contrast way.
Yeah, I think the problem is going to be, as Amit mentioned, the noise. The background noise is too much, and ability to, even in sporadic non-chronic pancreatitis background, it's very difficult to pick up early pancreatic cancer, and in the setting of chronic pancreatitis, it becomes enormously difficult. What is coming down the pipeline are tests, blood tests that apparently claim to pick up cancer early. The problem there is going to be to understand what part of the pancreas the cancer might be, and do you offer a total pancreatectomy if you don't know where it is going to be. So, but I think we will make progress in this area, but it will take time and maybe take a different direction than where we are now. But certainly, Ramesh, your thoughts on how you approach somebody who's suspected cancer?
I agree with Amit that the cellular yield of the EUS also, FNA would also be poor. So you would not get a positive report even if you had malignancy, for instance. So you have to have a high index of suspicion. If there is deterioration of diabetes, for instance, if there is change in the quality, in the type of symptoms, then you have to suspect cancer. A high quality pancreas protocol CT would help. And there's one finding that our radiologists has picked up, they're attempting to publish it, that by and large, the chronic pancreatic tissue is low enhancement. But relatively, if there are higher enhancement areas within this low enhancement, that is almost in their observation pathognomonic of pancreatic cancer, and we are prospectively applying this criteria to pick up more cases, and hopefully I'll be able to give you more data. But for the moment, it depends on a clinical suspicion. Patients who have jaundice and biliary obstruction are more likely to have cancer, and that's highly sensitive, especially if bilirubin levels are more than 5 or 6 milligrams percent or over 85 micromoles per liter.
Great. Thank you. Thank you for that. So I figured we can do the cases just so that it'll generate some discussion on relevant topics. And then we can take remainder of the questions if they're not addressed during the case discussion. So if I may, I can start with the first case here, which is an interesting case. Just before we start, I wanted to share what we see in India now for Dr. Chari and other international audience. So at Midas, we see about 200-300 patients of chronic pancreatitis every year, and an average age of 41, plus minus 14 years. And you see its majority were male, 87% is what we've seen were male, likely from chronic alcohol consumption being predominantly in India in males. Only 3 of our almost 660 patients had pancreatic cancer. And again, this is all based on our CPT ICD coding. So this is not a granular data done in a proper methodical research manner. 13% had pseudocysts. Only about 17 patients had LPJ. And in fact, even the RCPs were done in only about 22%. Not to say that they could have gone somewhere else and gotten the RCP, but in general, a lot of patients were sort of asymptomatic to require any major interventions. So we like to have a team approach for management here. This is during COVID times photograph as we all dressed up here. We have our radiologist who's an experienced, excellent radiologist with Yogesh, who's on as a panelist now, GI surgeon with all gastroenterologists, and I do the function of the advanced endoscopist here. So this is what ultimately is required, and we'll have sort of a talk on this later. All right, so this patient which we saw was a 16-year-old female with history of recurrent episodes of abdominal pain and weight loss in 6 months. Examination was significant for mild epigastric tenderness. Labs were essentially normal except for some low albumin level. Labs including CBC, LFT, KFT, lipase were normal. Ultrasound showed a dilated main pancreatic duct. So this patient had a CT scan. This is all prior to presentation. And as you see here, the duct is very diffusely dilated, and sort of, I'll just pause here, has some sort of filling defects, what you see. And per radiology report, the Hounsfield units were low, and they could not confidently say what the diagnosis was. There's an outside MRCP, not the best quality images, basically a fairly diffusely dilated main pancreatic duct, and can't make out much with that. So the patient, well, based on this appearance, what do you think it would be the differential diagnosis? Throw it all.
Sorry, what was the presentation? I missed that.
She had abdominal pain episodes, recurrent episodes of abdominal pain with normal lipase, normal labs.
Oh, I see.
Slightly low albumin level. She's 16.
16?
Yeah.
Okay.
So whom are you asking, Saurabh?
I'm just asking, what are your, well, it's a little bizarre.
Okay.
What would your thought be? What would you think it would be?
Was there associated back pain or only abdominal pain?
No, she did have sort of pain, abdominal going to back. So more.
So this is, for me, this is classical idiopathic or tropical chronic pancreatitis, what we see in our country.
Right. Okay.
If you don't tell about the age of the girl, I mean, one would probably say it's a main duct IPM, but if you say the age of 16 years female, and that kind of gets ruled out, and that's what I would agree with Dr. Naidu.
Right. Exactly. Yeah, that's the thing. Being with Dr. Chari, we saw a lot of IPMN, and we did a lot of studies on main duct IPMN. So this is the thing. I mean, the appearance, what classic picture of pancreatitis we think of as calcifications, and we did not find that in this case. And the appearance of the diffusely dilated duct, but then the age was not going in favor, which was 16. This is, if it was a 65-year-old male, I would be more concerned of a main duct IPMN.
Yeah.
But the young age was just throwing us off. So what Dr. Hariharan, if you have questions, you're saying something, yeah.
Yeah, I was wondering why you did not consider those so-called low Hounsfield images as stones. The opacity of the stone on CT scan depends on the calcium carbonate content, and that's very variable in pancreatic calculi, as you probably know. So I think they are stones.
They're soft
the duct
stones.
is dilated. Yes, they are soft stones. I would have liked to see the plain CT. And Suresh did mention that even when only the CT picks up my small calculi, which the plain X-ray does not pick up, and the MR doesn't pick up. But at surgery, we found stones in patients where even the CT did not show anything. And there were large chunky stones as well. And we got X-rays done of them, and they didn't show up on the X-ray. So then we did further analysis, and we find that the calcium carbonate content is less, and that's why the stones don't show up in X-ray. This is classical. Amit, what Amit said is absolutely true. So 16, yeah.
Predominantly proteinaceous balls will not have
with some calcium content, but not enough to show up. Not enough to show up on the ACT.
Right. If you ask me personally, all stones in there's a plug of protein on which calcium gets deposited, and the amount of calcium decides the hardness of that stone. And CT and plain X-ray, every patient, we also do a plain X-ray abdomen or fluoroscopy. Because if you see these stones on a plain X-ray, that means these may not be possible to remove by simple ERCP. They are going to require ESWL. But if you find filling defects on MRCP and you don't see them on plain X-ray, that means you can directly proceed with an ERCP if you're planning endotherapy and you don't need ESWL. That's the most important deciding factor whether ESWL is required or not required.
And now there are recent studies also which shows based on the Hounsfield unit, you can predict if the ESWL is going to be successful or not. Like thicker the stone, the chances of non-success is higher. So there's some studies from, in CT, Yeah,
absolutely true.
No, great. Thank you. Good points here. So anyways, the patient actually was referred for EUS and possibly FNA if there was mucin deposits or so inside. So we just see these sort of hyperechoic globular masses in there, and the FNA was proposed. And we did attempt EUS FNA, but just as you would expect, it wasn't really helpful, and it was non-diagnostic. So my colleague, who's a gastroenterologist here, did refer the patient, and he was concerned that this could be main duct IPMN, and he suggested maybe have a surgical evaluation for total pancreatectomy. So we did have a bit of a discussion between ourselves.
Sorry, Saurabh, what did the ampulla show? Was it wide open?
Yeah, I'll show you. The next slide will be that. So this was the concern that was raised, and was basically referred to us, said, you guys discuss it out, and we sort of spoke it between ourselves, and we said, let's go ahead and let's get a definitive answer, and therefore we went ahead with ERCP, and the ampulla is actually normal appearing, and we loop the wire. Did a good sphincterotomy. Okay. And then we proceeded with pancreatoscopy to visualize and see what is inside. And this is what probably was expected, was all these little ovoid masses.
Soft stones.
Yeah, so these were all little non-calcified soft stones filled up the whole main pancreatic duct. So we did do sort of some attempts to confirm that and get some of the stones out, but somehow it was a bit of a challenge to get these out. So anyway, since it was a more sort of an initial diagnostic ERCP, we placed a stent and came out. And was discharged on, patient was stable, did fine, was discharged on pancreatic enzymes, antioxidants, and a diagnosis of early chronic pancreatitis was made with non-calcified stones. Now, patient was asymptomatic for a month, started having the pain again, and now apparently she noticed a stent in the stool. Doesn't usually happen, but now what would be the next best course of action? Dr. Maideo did allude to ESWL, maybe needed in this case, or would you do a sphincteroplasty rather and remove, or would you consider surgical intervention? Dr. Ramesh, Dr. Maideo, group.
Well, according to me, the next best course of action is completion of endotherapy. They have to do it completely by doing an endoscopic pancreatic sphincteroplasty. So open up the pancreatic sphincter up to 12 mm CRE balloon, and all these stones can be taken out probably in a single sitting of ERCP. But don't use a Dormia basket. We have to use a balloon, because when the stones are soft and they do not have too much calcium, they don't need ESWL. All that they need is proper sweeping of the duct.
Right.
And if you once you clear the duct, this patient will have excellent clinical course.
Right. Agreed. And how long after the initial ERCP did the stent fall off, sort of?
About a month later.
Okay.
Right.
So Dr. Maideo, how much time do you recommend for the stenting? How long the stent should be kept for the audience?
To tell you the truth, I would have completed this procedure in the first ERCP itself.
Yeah.
I would not have placed a stent at all. So after clearing the duct, I would have placed a 5 French stent only for a couple of months. And next time, just go in, take out the 5 French, make sure that the duct is clear, and then give the patient a stent-free trial.
Yeah.
Right. Agree. No, thank you. So I think that was, I agree with you, and this was our plan as well. This is what we recommended. This was not our patient, and the team, they were, the overall feeling was a surgery would be more better as a course of action, as my referring was insisting on surgery. And so we decided to not offer endotherapy, although that was something that we did propose. And we have Yogesh on board, so who did the lateral pancreatic vaginectomy for this patient. And I'll just play the video so Yogesh can sort of take through the case.
So as it was proposed and decided that one time go, if we want to give the cure to the patient, so we went ahead with surgery after complete exposure. Duct was a straightforward palpable duct. We opened up the duct, and as expected, these were very small and soft stones completely embedded in the duct. The duct was opened up completely from tail till the ampulla. We could enter our Leahy's forceps, or in fact an infant feeding tube through the ampulla into the duodenum. A complete lateral pancreaticojejunostomy was done for this patient. And this surgery has been done around 1 year back. Until now, she has not came back to us, or even the referring physician. She has not gone to that referring physician with pain again. So an expected surgical result, pain-free interval of 1 year, more than 1 year it's been there till now. Thank you, Saurabh.
All right, thank you. Okay, so that was the first case there. Thank you for everyone's input. Bhushan, do you want to share the next case so we can go through some of the
Yes, sir.
that? Yeah.
Definitely.
Let me just stop sharing here. So, Dr. Maideo, in this case, ESWL would just not be required, just because you can sweep it out with a balloon sphincteroplasty.
Yes.
But is it that early chronic panc, say if there was you even have to do ESWL to break these stones, or you can just do without it?
See, I will not call this early chronic panc.
Yeah.
This is a full-blown chronic panc, but the calcification is not sufficient. So the stones are not hard enough. That's all.
Right.
But the pancreatitis has full-blown chronic pancreatitis. But
It says established chronic pancreatitis.
Yeah.
Right.
The point is that ESWL is required only if you see the stones on the X-ray. If you don't see the stones on X-ray, ESWL has no meaning. You can easily take them out by ERCP.
Right. Agreed. Yeah, I think we should have pushed for ERCP to possibly try and get it out.
Definitely.
But anyways, patient is doing fine. That's what matters.
Doing fine, yeah. That's what is important.
Just a comment. Saurabh, when I see patients with chronic pancreatitis, I have many considerations in our multidisciplinary program as to how we should address these issues.
Yeah.
If you have a patient who has alcohol abuse, and then there is the prospect of withdrawal of an inciting factor or a potentiating factor, somebody who is smoking, and then we can usually counsel them to get out of this habit, and also perform endotherapy. And then the prospect of making a lasting impact on the disease is substantial.
Right.
Whereas if you have a 16-year-old girl, perhaps with finite financial resources,
right,
and who is not yet diabetic, and if you hesitate to perform a one-stop approach,
right,
you're probably not, there's no doubt that technically it's endoscopically doable, but with improved endoscopic skills and improved surgical skills, anything is doable. Suresh said we need to resect undilated ducts. No, we don't need to do them. We can drain them perfectly. So similarly, endoscopy can get anything done anywhere. So that's not the point. The point is, what would you apply on whom? And here we have a 16-year-old girl who has no risk factors that you can abolish. So the only thing you can do is what you do on the pancreas. And therefore, I tend to think that your decision was perhaps better. Although Amit is shaking his head sideways, but I just have to tell you tongue in cheek that these 16-year-olds, after their long stint in Mumbai, do come down to Cochin for their final intervention.
Thanks a lot.
Can I intervene? I would like to comment here. Want to comment here. Small thing. Ramesh, this is not a patient where we have to keep on repeating endotherapy. This is a classical scenario where one single session of ERCP will clear the duct completely. Plus, we are achieving a balloon sphincteroplasty. So we are ultimately achieving the same what you are going to do in surgery. You are going to drain the duct after removing the stones. We have achieved a complete drainage. There are no strictures in the duct. The whole duct is open, dilated. We have removed all the stones. So this patient only has one stent removal after 2 months, not coming to back again and again. So even with limited resources, we are going to give her a complete cure. Not cure, I will say, but good clinical result.
A good number of these patients get calculi again, and they need more endotherapies. And we've done them in these cases too. And they have a lifetime. They have a lifetime ahead of them. Well, I rest my case.
Okay.
We'll have more debate. Similar questionable case. All right, Bhushan, if you can go ahead. Thank you.
Okay. Yes, sir. Good evening, all of you, sir. 37 clinical case in came to Midas. She is again a very young.
Bhushan, I forgot to introduce. Sorry, Bhushan Bhavre is our consultant gastroenterologist who's very interested in pancreas, and he worked he was trained at Asian with Roop.
He was our student.
Yeah.
And we are glad to have Bhushan here. Thank you, Bhushan, for presenting the case. Yes, thank you.
Yes, sir. Thank you, sir. Yes, sir. She is again a very young 24-year-old female. She was diagnosed outside to have an acute pancreatitis with peripancreatic fluid collection because she has become symptomatic since last 1 month. Though she gives that she has some episodes of an abdominal pain in the past also. She was referred to Midas for drainage. On blood profile, we showed a mild leukocytosis, normal kidney function test, blood sugars, liver function test, except with mild hypoalbuminemia, with normal lipase by the time she came here, and normal PTINR. The etiological workup of serum calcium, PTH, lipid profile was negative, and ultrasound what we did, we showed a very large, well-defined fluid collection with no obvious gallstones. So we did a CT, we show a very isolated, large, well-defined fluid collection, peripancreatic fluid collection, and with no obvious calcifications in the background. So we decided, since the patient having a symptomatic peripancreatic fluid collection, and we decided to go for endoscopic ultrasound drainage, which was performed by Dr. Saurabh.
Okay.
Yeah.
So in this particular case, we use the cautery enhanced lumen opposing stent, the hot Axios. I find it easier, but it's, of course, the cost is a barrier. So here we deploy the cautery enhanced stent across the gastric wall with the internal flange being deployed in the collection, actually, more like a pseudocyst. And here we also sometimes place double pigtail stent, which is what we chose. And this procedure was uneventful, done in 5 minutes or so. Next, Bhushan, you can go on.
Yeah. So it's just post-procedure, patient was completely asymptomatic. We do a screening sonography mostly over 24 hours, which was a complete resolution of cavity, and she was discharged. Presented 4 weeks later with recurrent of abdominal pain, and when we did a sonography, we showed there is a completely collapsed cavity. We see the cystogastric stent was in situ, and this time we found the PD was dilated to around 8 mm. So as before reviewing cystogastric stent and this cause of dilated PD, we ahead with the ERCP. So we did in ERCP, major papilla was cannulated, but we found that a guide wire could not be inserted deep. So we did a pancreatic sphincterotomy. Yes, so we can see the guide wire got not able, the contrast was not able to completely opacify the DPD. So by the time we also found that his minor papilla was also quite prominent. So we did minor papilla was prominent. So we cannulate the minor papilla, as you can see. We can see this wire was going deep into the PD, and then we obtained a pancreatogram. You can see very nicely there is a short stricture in the mid body, and also there is a proximal stones beyond that. Yeah. So there was a filling defect, there was a stricture, what we can able to see here. We did a minor papilla sphincterotomy. Sorry. And we place a 10 French stent was placed. Yes, we can see a stent. So post-procedure, the pain was subsided, and the patient was started on pancreatic enzyme replacement therapy and antioxidant. So here the pancreatogram showed a divisum, what we see, a single stricture, and the proximal stone. So I really asked our panelists that, yes, there is, what does the pancreatic divisum have a role in development of chronic pancreatitis? So anyone can answer this question, sir?
Chari,
I think pancreas divisum per se is unlikely to cause acute, recurrent acute, or chronic. I think based on what we have observed over these years in few of our studies, it appears to have a gene environment interaction, at least because we had published a paper where we saw presence of few specific polymorphisms, the cathepsin B gene and one of the PRSS variants. If these are combined with pancreas divisum, those patients have a higher risk, at least 3-4 higher risk of developing recurrent acute pancreatitis. So the same thing could hold with other risk factors if there is a combination of divisum with hypertriglyceridemia. We don't know that. That is just a hypothesis that we think of. But genetics, yes, definitely we have seen pancreas divisum and genetics, if they are co-occurring, the risk of recurrent acute pancreatitis gets higher.
Definitely, so yeah.
Dr. Chari, I don't know what he thinks.
So is the disease, is the chronic pancreatitis confined to one or the other part of the gland?
No, sir. It was just a ductal dilatation with stricture and stones, sir. There was no obvious parenchymal calcification.
Of the main duct.
Yeah, it's a main duct of the main duct.
What about the ventral pancreas?
Yes, what ventral pancreas was very kind of able to visualize, and I can show a pancreatogram.
Yeah, I don't think we have put the CT here.
CT here, yes, sir.
To give you the parenchymal appearance. Sorry for that. Yeah.
Yes, but there was no calcification as such in the parenchyma, sir.
Yeah.
Large duct disease. Yeah.
Yes, sir.
Yeah, again, this is true and unrelated, or is it connected? Hard to know. In some patients with chronic pancreatitis, there appears to be no other risk factor except for the presence of pancreas divisum. So, not sure that anything can be differently will be done now.
Yeah.
In terms of that, doesn't mean that every pancreas divisum should be cut. So I think that.
Yes.
Right. Dr. Ramesh, you wanted to say something?
Yeah, I was going to just say that. Isn't there a stone in the body of the pancreas on the imaging?
Definitely.
Yeah.
Yes, sir. Yes,
Yeah.
sir.
So there is calcifying pancreatitis for sure.
Yes.
And it appears
Yes.
from the morphology of the ductogram, it appears that it's a chronic pancreatitis largely affecting the dorsal anlage,
Right.
which is pretty common
Yes,
in pancreas divisum.
Divisum.
The ventral portion is relatively less affected, but it will get affected, or it could get affected in the future. There's nothing to prevent it from getting affected as such. So here these two are completely unrelated entities, but the pathology seems at the moment to be confined to the dorsal anlage.
true, sir.
Okay. Bhushan, we can go to the next
Yeah.
question.
So again, sir, I can really ask the question, right? Yes, after drainage, and what is the role of exactly PERT, pancreatic enzyme replacement therapy, after endotherapy?
So
Ready
I
put
see
for the
that every
questions.
patient is getting PERT.
Yeah.
What is the
Yes.
indication?
Yes, sir. So,
What is the indication?
Right.
yes, sir. So especially that's always debatable, sir. But always we discharge the patient. Always tell we just take a PERT. Do you have any relevance, sir? That was my idea. Put in the question.
Is this the live 52
Yeah.
of pancreas?
Yeah, so the problem is once you start it, you don't know when to stop. I mean, if there are no
Absolutely, sir.
definitive indication, if there are indications, fine.
Yeah.
Yes,
So
sir.
can I
I don't
come in here?
I don't use it for pain.
Yeah, for pain, definitely no. For pain, definitely no.
Pain.
Yes.
Yeah, the more question
Yes.
is certainly in patients with pain, do you feel it has any difference, or guidelines don't see?
No.
Yeah.
No, for pain, actually, there are a few meta-analysis which studied different papers. Most of them had shown there is no benefit of PERT on pain, except for two papers, I think, not very well done, very old paper, which shows non-enteric coated tablets might have a role in a small subset of patients, not very sure. We need to replicate that data probably. But
I'm assuming, sorry,
yeah.
I'm assuming there's no non-enteric coated version.
In India, no. Well, there is one preparation called Biocase. I think, I don't know if it's available in US now or not.
Yeah.
Biocase. But in India, whatever we have are enteric coated so far.
Absolutely. Yes, sir.
So I personally feel that the role indication for pancreatic enzyme therapy in such a situation will be only if there is steatorrhea.
Yes.
Right.
Yeah, agree.
Yes,
Definitely not
agree.
for pain.
Yes.
I completely agree, sir. Yes, sir. So yes.
How about antioxidants?
Yes. What about antioxidant? The same thing. Yes, sir.
Well, so here's the difference between the two. What is the cost of PERT?
Yes.
Right.
I don't know. I'm asking because I think in US is 10,000 units is $1.
Mm.
India is
So
also
if
quite
the patient is
expensive.
paying out of pocket.
We have quite expensive, sir.
Quite expensive in India.
Yeah. Like,
Yes, sir.
So antioxidants,
Yes.
on the other hand, are pretty cheap. So if it has any benefit, that's okay. But enzymes are very expensive and they have to be used for life. So I don't know. I tend to be less liberal with enzymes than I am with antioxidants. And some of my colleagues here are liberal with it. They give it enzymes even for IBS. So the patient with IBS swears by enzymes. And I tell them you're taking an expensive Imodium. My colleagues say, hey, how do you know it's not working? And I said, well, it's a placebo response. So.
Yeah, I've not seen that yet in India, but in the US, this was seen frequently. A trial of pancreatic enzymes in diarrhea patients.
Because they do
antioxidant.
fecal elastase in diarrhea predominant IBS, and it's low.
Yeah, obviously
So
it will
that
be low.
becomes the reason for going for it.
Yeah.
So Roop Jyoti, any role of antioxidants?
Yes, antioxidant could benefit a subset of patients, not all patients. Patients who are on alcohol, actively smoking, they are very unlikely to benefit. And younger patients, idiopathic, who are not taking opiates, those patients are more likely to benefit. But then we have to use the right choice of antioxidant. It has to contain something called methionine, because that is responsible for exocytosis of this enzyme into the pancreatic duct. And because of oxidative stress, that gets depleted. So there is the activation of the enzyme within the acinar cells. So we have to send out the enzymes into the outside the acinar cells, and that's where methionine comes in. So if methionine is there, it should work in a subgroup of patients.
Yeah.
I'd like to ask all the panelists one simple question. Would they like to consider doing fecal elastase guided PERT in such patients?
I won't do that.
if you're not symptomatic, that is, if you don't have symptomatic steatorrhea, because our patients tend to restrict fat the moment they have pain.
Yeah.
And so you always get a no steatorrhea report from them if you take the history. But actually, if you give them a standard fat diet, all of them are steatoric. So would you consider using a fecal elastase, Suresh, to tell you how to go, which way to move?
So we've just written an entire review based on the role of fecal elastase and this and that. So the problem with fecal elastase is that it doesn't correlate very well with steatorrhea until the levels go down below 25. Above that, the sensitivity and specificity are very variable. And so the cutoffs that are used by the company are actually quite meaningless. Less than 200 is abnormal, less than 100 is severe. It doesn't make any sense.
Yeah.
And that's not surprising. Same thing with lipase, same thing with anything else. So the question is, how do you decide? And this came into existence because for cystic fibrosis, it's all or none. Children have either no function or they have function. So the same doesn't apply to humans, where there's a whole range of fecal elastase where the gland is in dysfunction, but is not in failure. The only way you're going to diagnose failure is by doing fecal fat, or the patient clearly gives symptoms of steatorrhea. So I'm not sure that it's easy to do it based on fecal elastase. You are asking the question. So I would do vitamin A and E in that patient. If the patient is managing their symptoms by calorie restriction and they're not losing weight, then if vitamin A and E levels are low, then they will need PERT.
Yeah.
I think Roop has also suggested that A&E and weight gain or weight loss may be incomplete signs of PEI. So I think I would have like to suggest that if you had very low fecal elastase, I would certainly consider adding the pancreatic enzymes, regardless.
What is very low? That's low.
The question. Your 20 is exactly what I would think is very low. Mm-hmm. And it's often very low in spite of the patient not having any symptoms.
I agree. I mean, so there is another thing that is very literally most people wouldn't have heard, and that is extra pancreatic lipolysis.
Yeah.
And so that's another reason why fecal elastase is hard to use as directly, because some of these people with slow loss of pancreatic function end up enhancing gastric lipase and doing a lot of extra pancreatic lipolysis. So.
And in the last couple of years, in several of our research projects, we have been doing fecal elastase in both patients and controls, healthy controls. Of course, they're not paying it. We are paying from the research funds. And even in the healthy controls, it was very, very low, even to the tune of 25, 50. So, and they do not have any symptoms. So that reduces the specificity of the fecal elastase, which is around 30 to 100%, a wide range. So that's why in my practice, I don't use this thing, fecal elastase. Of course, I go by the clinical parameters, EA. And I think B12 could be a good surrogate, because B12 for absorption requires the R factor to be cleaved by pancreatic colipase. So no one has studied that. Maybe someone can take up this study in a systematic B12 deficiency. And we do see a low B12 in many of these patients. So that could be a potential marker, which is easily available.
Thank
you.
Sir.
Yeah.
All right.
Yes, sir.
You want to go ahead?
Yes. Yes, sir.
Thank you.
So patient was doing well. He was scheduled for ERCP after 3 months. So we can see a plastic stent was removed. We again cannulated the minor papilla. We can see there is a prominence of stricture. We can see at the mid body. We dilated the stricture with the 4 mm biliary balloon. And we did an upsizing of the stent by putting a 2 stent. One is of 10 French single pigtail. And also we do a minor papilla sphincteroplasty, chloplasty before placing a stent. So one is 10 French stent we placed in the PD, and another 7 French stent single pigtail place was placed in the PD. Okay. So yes, sir, the core questions always comes like, yes, whether we are
Probably the most
doing an endotherapy, or whether it's called as an early surgery for chronic pancreatitis. It's Amit sir would answer, sir.
Right.
Yes, sir.
See, because this looks like one single stricture in the body of the pancreas.
Yes, sir. Yes, sir.
So as an endoscopist, I will try to manage this endoscopically, but we go according to our guidelines. It's not that you keep on managing these patients endlessly. If your stricture does not completely resolve after you have achieved the maximum diameter stents of maybe 2 10 French stents and leave them inside for a year, and after 1 year, if you find that the stricture is still persistent, you should give the patient a choice for surgery. Or if the patient refuses surgery, then you can put them on a long-term stenting protocol where you continue to place the 2 stents, make it into 3 stents, and then again leave it for 1 more year. But I personally feel that if the stricture does not respond to your endotherapy for more than 3 years, we should not keep on persisting with stenting. Send the patient for surgery. I don't want to start another debate with H. Ramesh.
We are trying to stimulate the debate and more discussion.
Yes.
And have some evidence to generate that debate. Thanks. Thank you.
Yes. Yes, sir.
Yeah, Dr. Ramesh.
So yes. Yes, sir.
All right. So
Ramesh,
let's start
sir.
with the escape trial, Bhushan. I think that's
Yes. Yes, sir. So just as I say, we don't have to debate. So there was a trial recently, and previously it was 6 NEGM trial favoring surgery. So it was really fresh into recently came in JAMA. What is the effect of early surgery versus endoscopy step on pain in a patient of chronic pancreatitis? It was an unblinded, multicentric trial from a 30-day Dutch hospital where 88 patients were randomized to 44 into surgery and 44 into endoscopy, and the criteria of patient was having a dilated pancreatic duct who are on opioid dependent. And the primary endpoint of the trial was like, what is the pain measured by the score system at the end of an 18 months, and secondary outcomes like pain at 18 months, disease progression was measured. So what they found as you can see in first left-hand side, that a mean score after 18 months was quite low in surgery as compared to endoscopy. And also the secondary outcomes, that complete pain relief was far better in surgery as compared to endoscopy. But I really go into the things that, when we go into and what is that, they found that a similar outcomes to surgery, if we able to complete the duct clearance achieved with ERCP, as you can see on the right hand side. So if you achieve this green graph is a number of patients who was able to achieve a complete duct clearance, and it was compared with the surgery, it was almost found to be as equal to as surgery. So always this trial was open for critics.
Okay.
And
thank you. Thank you, Bhushan.
I think in this kind of trial, the follow-up period is a bit less. I mean, we have to follow them up for a longer time to see the actual effect. Immediately within next 1 to 1.5 years, there could be effect by both endoscopy and surgery. But how the long-term effect goes, that is, I think, something more important to be seen.
I agree. Yeah.
So, Bhushan, you can go on with the comments, right? So, first one was there's some debate whether ESW was not optimized. They did 3 sessions for these greater than 7 mm stones. So, Maida, what are your thoughts? Would you do more, like 5, 6 sessions?
It is not the number of sessions, Saurabh. What is important is what is the end point of ESWL. The end point of ESWL has to be pulverization of the stones, not fragmentation. So when you do a high definition fluoroscopy or X-ray after ESWL, you should actually see that the stones have now scattered in the duct instead of being at one location. So it is called as a Steinstrasse appearance. Second is your fragments have to, of powder has to be less than 3 mm. So it should become, the denseness should go away. In some of the patients, the stone should not be seen at all. It will get disappeared. So the end point is important than the number of sessions.
Right.
Because sometimes we give 8,000 shocks, 10,000 shocks every session.
Okay. It was not well tailored.
And what kind of instrument was used, sort of, for this ESWL?
In this study, I think they do mention the Dornier ESWL thing at Amsterdam Medical Center.
Yeah.
I don't know the exact sort of. Bhushan, would this be applicable to India? The study results. We have a lot of tropical chronic pancreatitis. They had 70%, 80% alcoholics in their study. We don't
Not
necessarily
applicable.
have that much. We see you feel the morphology in tropical chronic pancreatitis a little different from alcoholic.
Yes.
Right? Okay. Next, they obviously had smaller number of patients, which is about 40 in each arm, 44. Now, if you look at the data, 50% in both arms had an enlarged pancreatic head, 85% had exocrine insufficiency, 80% had continuous pain. Question is whether this is an advanced disease, which we would argue yes. Endotherapy studies have shown that earlier endotherapy is more beneficial than advanced disease. Any comments on that?
Yeah, I think as the disease progresses, sensitization happens and patients start to develop neuropathic pain. And once neuropathy has set in, even if you remove the pancreas, the patient still will have pain. Like 40% of total pancreatectomized patients continue to have pain. So if indicated earlier, the intervention, be it surgery, be it endotherapy, as indicated, would be better. And
Right.
recently, what we observed was like we followed 507 patients over 6 years. And patients who got endotherapy earlier on in the disease course, and if they did not have diabetes, then diabetes development was delayed by around 3 to 3.5 years. Who has diabetes already, the diabetes do not change. But if there is no diabetes, the diabetes could be delayed. So that could be another advantage of early intervention whenever indicated.
Right. Okay. Next. So they did not, well, the complete duct clearance was achieved usually in 75 to 80%. In this study, achieved in 60%, a little less. They still ended up sending the patients to surgery in the endoscopy arm, about 62%. So next question. So the question really, as we alluded to, is if complete duct clearance is achieved, perhaps you will have outcomes as similar to surgery, perhaps with lower complications. What's the thought?
Saurav, I just want to come in here. You have written here that complete duct clearance could be achieved in 75 to 80%. And what percentage of these patients were alcoholic etiology? 80%, right?
I think
Yeah,
I'm
majority, sir. Majority.
Now, achieving a 75 to 80% complete ductal clearance in alcoholic pancreatitis, that itself is appearing a little bit dicey, because all the studies so far for alcoholic pancreatitis, complete ductal clearance can be achieved in a maximum of 40 to 50%. 75 to 80% ductal clearance is unheard of.
Sorry, I apologize. What I meant to say is in Indian studies, if you just consider all comers, it's 75 to 80%. In their study was 60%, which probably is from the alcoholics in their study, which is why.
Yeah, even 60% is high. Because, alcoholic pancreatitis usually have multiple strictures also. It's not dilated ducts with stones, as we see in our scenario in India.
Right.
So the endotherapy invariably fails in patients who have alcoholic etiology. Right. It doesn't succeed so much.
Right.
Yes.
So Saurabh, there's
could I make a comment?
Yes, sir.
No, I have gone through this paper as well, and we did it with a journal club as well on this. The question seems to me as to how much we are willing to accept that if a multidisciplinary approach is brought to bear on a patient right from the start.
Right.
This is the critical point. If you place a patient in a trial, you have to counsel the patient, you have to tell them about all the options, and then you go forward. And then everything is visible to everybody. Whereas in a unilateral unit, which is publishing a pure surgical study or a pure endoscopic study, these are completely, secluded data, as I call it. And these figures of 75%, 80% depends on the fabric of the patients that came to them. As Amit said, the number of strictures, what is the type of patients who came to them, and of course the skill of the endoscopist. The follow-ups in many non-surgical series is really low, in the sense when patients don't turn up, they are presumed to be well very often. I remember in the 1,006 patients of Nagi's, the big paper, there was 60% follow-up. So it's really not fair to conclude that 85% had relief of pain on the basis of 60% of patients. So I think what we need to learn from this paper is that when a very organized, well-designed randomized trial was done in a very leading center in this country, in this world. I mean, we're not talking about it being done somewhere in, in Sikkim or somewhere. We're talking about some standard departments. We have got some data which is eye-opener in the sense that the clearance rates are somewhat different, as Amit mentioned, that the early results are better. It's not rocket science to say that the early results will be better if the stone clearance were complete. And Roop has clearly mentioned that if we want to count our chickens in chronic pancreatitis, we're going to count them 10 years on, not 1 year on. So even that the disease itself is episodic. You could have the next episode of pain only a year hence, and we could blame it on our surgery or your endoscopy. I mean, both of them could be wrong. So you take 10 years if you need long-term studies, like the Diuna Kahan study,
5 years follow-up.
Original, they did a 5-year follow-up, and that was an important paper. And I wish Bhushan had reviewed that, because that is very important. And it gives us lots of insights into the whole picture. So that's what I wanted to say. Thank you. I'm sorry, Suresh, I didn't realize you were beginning to speak and I started to speak. I'm sorry.
No. My only other question was, we don't know the benefit of actually cutting through the pancreas to do a Whipple. What is that filling open the pancreas? What benefit does it have for pain, as opposed to simply ductal clearance? And that is hard to tease out. So the neural cutting or whatever it is that helps, it's associated with filling open the pancreas. What does it have to do with benefit? But it's something very difficult to prove also.
Okay. Just that you can clear stones more easily, that's all.
And the question is it more than just clearing the stone? That's the question.
So my premise, as I've understood the diseases, seems to be that the stones lie where the strictures are. The number of patients where you have free floating stones just in a completely dilated duct is less than 30%. 70% have strictures. And where the stones are dense, there are strictures too. And so when you get at the stones, the strictures get fixed, perhaps. So that's the premise.
This whole thing is complicated by the fact that you have as many patients with the same stones and the same strictures who have no pain. So this whole argument becomes very difficult to put together when you know that there is an equal number of patients who are painless with the same disease as there are with pain. So what's the difference?
So
in that case,
no, we at the moment we are still in the primitive status of trying to resolve what to do for the painful pancreatitis. If we have a clear consensus on that, then we can try and hope to apply it to the painless ones. Isn't that true?
No, knowing why somebody's in pain and why somebody's not helps to understand whether the intervention, what is the right intervention for those patients. Anyway, it's difficult to answer, but I'm just saying.
Thank you. Okay, Bhushan, you want to go ahead with the case and then we can go through some. All right. So I think overall, whether we should do a surgery first versus endoscopy first approach, probably it needs to be tailored as opposed to taking one right answer from the mix. Certainly multiple strictures, significant stone burden, inflammatory mass, concern for cancer would recommend surgery first. Limited stone burden, single stricture, perhaps endoscopy first would be a better sort of approach than sending everyone for surgery. All right, anyway, so we can go ahead with the case, Bhushan, and then we'll go through the Q&As. Yeah. All right, Bhushan, I don't think we can hear you if you're speaking.
Bhushan is muted.
Yeah, I think he's muted. Never mind. So we did proceed with pancreatoscopy and laser lithotripsy for this particular patient. Just did a papilloplasty since it was through a minor duct. And then we used a holmium laser to fragment the stones, which you see here on screen. Okay. Bhushan is playing, right? Okay, can keep playing Bhushan. So anyway, it took us about 30 to 40 minutes. We pulverized most of these stones. Bhushan, you can move forward with the follow-up. Yeah, that's sort of another appearance there. Just, we see them fragmenting and then floating right there. Go ahead, Bhushan, move forward, yeah. And then we just did balloon sweep, what you see on screen. All the little stones were removed. We could get a 10, 12 mm balloon across the stricture. As you see, the stricture is a little more dilated than what we encountered initially. So we could achieve a good ductal clearance, and we reinserted the pancreatoscope to visualize the whole pancreatic duct to confirm clearance of the stones. As what you see, there's really little small fragments of stones remaining, but by and large, the entire duct was cleared quite well. Right. Okay. So in this case, as the contrast flew very smoothly across, we felt comfortable removing the stents and not keeping any stents across the stricture, although there was some degree of stricture there. Next, yeah. Just to review, Bhushan, you can go through this in the rest slides. We can make it brief so that we go ahead with the conversations. Oh, I think we can't have Bhushan's not audible. Anyway, so just this is a more recent technique. Again, can be discussed and debated over. But pancreatoscopy and lithotripsy, about 300 patients with a pooled success rate of 91%, fragmentation rate of 86%, and about 62% patients, I think, could do it in one session. All right. Thanks, Bhushan.
Yeah.
They did have a few patients with pancreatitis, but by and large, less than what we have seen overall. So anyway, Bhushan, you can go to the next slide.
Yes, yes, sir. So already discussed this roll-up parallel. So post-procedure, the patient was doing well. He was asymptomatic for again 3 months, developed again the recurrence of the pain. This time we had normal lipase level, and imaging shows a dilated duct. So we already given a stent-free trial for the patient. We can see that there is a persistence of, and still there is a stricture. We can see it was smooth. There was no obvious filling defects seen proximal to the stricture, what has been seen before. And this time we again did a dilatation of stricture, and we placed a 10 French stent was again placed into PD, to minor papilla.
Okay.
Yes, sir.
We can.
So post-procedure, there is no pain, and currently, as per the patient, like from last 4 months, third month is in there. Patient did February, the last ERCP. Currently, his patient is doing quite well with no pain as per the patients we call on phone.
Okay.
Yes, sir.
Thank you, Bhushan.
Yeah.
Happy to have comments.
Yeah.
Team.
Hello.
Yeah, you can go ahead and finish. Yeah.
Yes, sir. Yes, sir.
Dr. Mahadev,
stop sharing.
I know you would prefer ESWL. I know you've done this, or is it something that you're flexible about?
Not necessary. I mean, ESWL is, if we have it available, then we would have done ESWL first if these stones were already opaque.
Right.
And otherwise, doing a pancreaticoscopy and laser is also a good idea. But sometimes, going across a stricture, going across the genu, bringing the stone in front of the laser fiber becomes a difficult proposition. Yeah. So ESWL becomes easier.
Right.
Because of the curvature of the pancreaticoscope, the stone may not come end on in front of the laser fiber, and then you'll keep on shooting, but it will not reach the stone. It may go on the wall of the duct. So that's why we prefer ESWL as the first choice.
Right. No, I hear you. And I think in this case, a pancreatoscope is 10 French. So if you could place a 10 French across a stricture, in theory, you can get the scope across. And that's what encouraged us to proceed with this approach. Because we have 10 French and 7 French stents. We said the scope should go across. And we were happy that we could manage to get it done. And all right. So I guess we could go ahead with a lot of questions and answers. And I know this is a little late in the day. It's 9:10. But let us go ahead with some of these questions at least, so that we can try and answer these for the audience. All right. So this first question, if acute portal vein thrombosis occurs in acute on chronic pancreatitis, is there a place for anticoagulation? From Dr. Fernando Pool from Sri Lanka. Yeah. Any
Answer is no.
No. Okay. All right. So there were some questions. All right. Let's see. I think there's a lot of, okay. Which stent would you use in these cases? I believe this is related to the first patient, Dr. Maido. Single pigtail stent or straight stent? Single pigtail stent has tendency for self-expulsion with peristalsis. Any preference in stenting?
For which case?
Pancreatic cases. So the first one, I think this question was at 8:34 p.m. So
in general,
yeah,
single pigtail stents are considered to be safer, because even if the stent comes out, it will not impinge and it will not perforate the opposite wall of the duodenum and not cause any trouble. However, in certain situations, we can also place a straight stent provided you have made the flaps properly. So if you make sufficient flaps inside as well as outside, then the stent will not come out on its own.
Okay. Okay. So I see Dr. Hariharan had to leave. Thank you so much for coming. I apologize we couldn't take one. All right, so then go to the question answers. Is CT abdomen a screening tool for chronic pancreatitis? General question. Dr. Chari, I think already alluded to this briefly, that it can be used among the patients, right?
I would agree that among all the imaging modalities, that it would be a good starting point. US has its differential, and so you can overcall chronic pancreatitis in the US. So starting with CT may be helpful, but it all depends on the context.
Dr. Shrikant Gopis asked, can we attribute 2-3 glasses of wine per day to chronic pancreatitis pathology?
So Dr. DiMagno actually had done a study looking at teetotalers, social drinkers, and alcoholics, and found no threshold for alcohol that was necessarily safe.
Yeah.
So,
and if this, even though literature gives numbers like 50 grams, 5 years daily, those kind of numbers, but then if the patient has another risk factor, for example, genetic risk factor, even at a much lower dose, they could have the disease. And another observation after the first episode of pancreatitis, I think that probably the threshold of next alcohol-related pancreatitis comes down. Even at lower concentration, you can have. So alcohol should be a total no question of 1 or 2 drinks.
Right.
Agree.
Right. I think we don't know the genetic makeup of the patient, so we just not tell what will be a contributing factor and how much alcohol is.
Yes.
Okay.
There may be a role for interaction between smoking and alcohol.
Right.
There are data suggesting that alcohol alone without smoking is not as big a risk factor.
Yes, yes.
So it's complicated.
Yeah.
All right. So which patients of Dr. Vaneet Jyoth is asking, which patients of chronic pancreatitis require gene analysis? How does how does associated gene mutations influence outcomes in divisum? And whether we do gene analysis in all PD patients? I guess there are 3 questions in there. Roop, Dr. Chari, you guys, which patients would require gene analysis?
I'd let Dr. Chari to answer that question first.
Well, we have recommended less than 35, where there is no other obvious cause. So in terms of pancreas divisum, first of all, I won't touch pancreas divisum unless they have documented pancreatitis. This pain business is nonsense. But in terms of pancreatitis patients with divisum, I'm not sure how the genetic testing is going to alter what I'm going to do, but I'll have Roop studied this better. I'll ask Roop to answer that question.
Yeah, so in our setting, for chronic pancreatitis, if the CP has set in, I don't do a genetic polymorphism testing because that's not going to change the outcome. If the patient is young, children, recurrent acute pancreatitis, children, family history of pancreatitis, young adult, family history of pancreatitis, recurrent acute pancreatitis, those are the patients where genetic testing could be helpful. And of course, if pancreas divisum is there, and we had observed this cathepsin B polymorphism that increases the risk if both of them are coexisting, the polymorphism and pancreas divisum. So in pancreas divisum, we would do with recurrent acute pancreatitis, not just incidentally detected divisum, of course. So these are the small groups of patients where we would, yeah.
My question to you, Roop Jyoti, is
yes, sir?
in children, if you find genetic abnormality, so how is it going to change your treatment?
Yeah, so that can actually be a double-edged sword kind of thing. So many patients are worried about the cause, why it is happening. And on the other hand, if you tell them that there is a genetic cause, they might be scared all throughout their life. So counseling would be extremely important. I mean, how you deal with the data and tell the reports. So what now recent studies have shown that there could be gene-gene interactions, which may be responsible for later on severe disease, or there is a gene called BAC2 polymorphism, which has been shown to increase the inflammation that may lead to a higher propensity to develop diabetes. So with this kind of data, if the early in children with recurrent acute pancreatitis, if we know the combination of genes, there would be hopefully a time based on current data where we could predict specific outcomes. It will take some time, but that's the direction. But at this point, we are not changing the treatment as such, but that could help predicting probably over the years what could happen.
So my question is,
if we say PRSS1 is positive, then these patients are high risk of pancreatic cancer.
Yeah, but the good news, the good news is PRSS1 and association of cancer is maximum with the R122H. There's a very specific polymorphism which is associated with hereditary pancreatitis, 50-fold higher risk of cancer. The PRSS that we see in India is a different, seen in the non-coding variant, in the exonic fragment. We don't see the PRSS 122H. I think we had got also only one patient which has variable penetrance and heterozygous, only one patient that we had seen over the thousands of testing that we did under different research protocols. So that's a good news for the Indian patients. And the most common that we see in our patients is PINK1, followed by cathepsin B. Cathepsin B is a gene that is not seen in the West. So people in the West have not studied that too much, or they find it difficult to believe that there is a gene like this, which could have. But in all our studies, all consistently, we do find that polymorphism, cathepsin B. So
one more very important question, that if you have a patient of acute recurrent pancreatitis and you find on MRCP pancreas divisum and genetic testing is normal, no mutation, will you treat or not treat endotherapy?
Tough question. Yeah, so again, if we see the prevalence of pancreas divisum, even many normal person have that. So by itself, pancreas divisum is unlikely to cause divisum. So I would rather.
But patient is having repeated episodes, 5 episodes in the last 2 years of acute pancreatitis.
Yeah, so that would probably depend on individual choices, because
what decision will you take at AIG? At AIG, what will you do?
At AIG, some patients do get treated with a sphincterotomy, minor papilla sphincterotomy. Me personally, if I see that patient first, and if the number of recurrences is not too high, or if the patient do not have, then I'd rather have a close clinical observation. But if they come with very frequent, as you said, like 5 attacks in 3 months, 4 months, then sometimes it's difficult to take a call. We might have to go ahead with the. So Dr. Chari wanted to say something
about this.
Yeah. This is a dicey situation.
Couple of comments. I agree with Amit. So the decision to do anything in pancreas divisum depends on patient's disability, and if the attacks are frequent enough, and the patient feels like this is interfering with their quality of life, and you have nothing else to offer, I think that's reasonable. But if the attacks are happening once in 5 years, I think we can do more harm than good.
Yeah.
So I think it's tailored to the patient's disability rather than anything else. And regarding Saurabh, your comment that mutation is associated with cancer, It's not the mutation that is associated with cancer.
Yeah.
I hope you're not.
The disease. No, I meant PRSS1 patients seem to have a high risk of cancer.
No. I don't. It has nothing to do with the PRSS1 mutation. PRSS1 is not an oncogenic mutation. Let's be very clear on this. PRSS1, SPINK1 are not oncogenic mutations. The only connection between PRSS1 and cancer is the duration of disease. If a PRSS1 patient does not get cancer, it does not have pancreatitis, the patient's chances of getting cancer are extremely low. There are 20% of patients with PRSS1 who do not get cancer. Their risk of cancer is extremely low. So please do not confuse the mutation with being mutagenic.
But if for tropical pancreatitis, they would be also young age onset patients now.
Yeah, they also have very high risk of cancer.
Right.
That's because if you start having pancreatitis in utero, regardless, it doesn't matter what, even if you're drinking in utero and getting alcoholic pancreatitis in utero, your risk will be the same as the PRSS1.
Agreed. So there was a paper from Pramod Garg's group
those who want to remove the whole pancreas use this as an excuse to remove the whole pancreas.
Yeah.
They label the gene as being mutagenic.
Yeah.
Which is completely false. There is absolutely zero evidence that
Agreed.
mutations are mutagenic.
So is the duration of inflammation? I mean, how long your pancreas has been inflamed?
If you get disease in your first decade of life, your chance of getting cancer by 40 or 50 is very high, regardless of what the mutation is.
Agreed.
Yeah, I think it goes in line with IBD, where we have cancers and long-standing disease. That's just, I guess, one point which has been asked a few times. Role of auto LSL transplant. I guess it's a long debate. We open this, but just what's the feeling? At what point would it be justified? I guess that's really the bottom line.
I think it's no different from the answer to the pancreas disease in question. If your back's to the wall, you have nothing else to offer. And I had patients who couldn't even get homeschooled. They were getting so many attacks, they couldn't even go to school. There, of course, you get a letter from the mother saying, "You give my life back to my child." So there is that whole spectrum. And then you take these patients with central sensitization of pain, and you see the pain persists after removal of the pancreas, and you think, what did I do here? So I think choice of patient is important, disability of the patient is important. And I think the biggest piece that is missing is long-term natural history of the disease.
Yeah.
All these glorious picturization of total pancreatectomy and islet cell transplantation is absent long-term history. You know, you do islet cell transplantation in a 10-year-old, you have no idea how they'll be at 30 years or 40 years.
Mm-hmm.
You know, the suicide rates in these patients, the poor control rates in these patients, we have very little information on that. As long as they're well controlled, everything looks good. But once they start losing their islets at 20 or 30 years after they transplant, then we don't know what will happen to them. So I think that the jury is still out about long-term outcomes, but short-term outcomes, for sure, they will do better.
Mm-hmm. Okay, thank you. Then this something else. In benign biliary stricture due to chronic pancreatitis, before going ahead with surgery, should we go ahead with fully covered SEMS or not?
So
either Roop, sir.
Indian.
Okay. Roop, I think we are missing you. See, I think we know that fully covered SEMS seem to work well for biliary stricture. Now,
recently there has been recently in Journal of Clinical Gastroenterology, there was a systematic review.
There's a recent paper
published on.
I think we have problems with Roop.
Center study. Yeah.
Yeah.
Can I talk?
Yeah, I think it's his internet which is a problem. Yeah, you can please go ahead. Yeah.
So recently there was a systematic review and meta-analysis published on comparing fully covered metal stents versus multiple plastic stents for benign biliary strictures related to chronic pancreatitis.
Mm-hmm.
And they have found that the first option should be a fully covered metal stents because the number of re-interventions are much lesser. However, the response rates of both reach somewhere around 80%. Okay, so around 80% now, especially with the fully covered metal stents, all that you have to do is to put it and leave it inside for 4.5 to 5 months, 4 to 5 months, and then take it out. And 80% of these strictures will resolve after a fully covered metal stent.
Yeah. So I felt a little longer, maybe like a year, or do you think 6 months is enough?
The meta-analysis suggests 6 months.
Okay.
Because any foreign body inside the duct will sort of cause sludge formation, stone formation, and then leave that stent inside for a longer time of period. You will start finding sludge balls and stones which are forming in the duct above the stent.
Right.
And then you come across all new problems which start adding in the patient's life.
So we'll just wrap it up in 2 minutes at 9:30 so that it's right for everyone. Thank you for everyone. Last, we'll take one question. Liquid biopsy for diagnosing pancreatic cancer in chronic pancreatitis. Dr. Chari, what do you have?
Yeah, so right now there are in the US, there are 4 liquid biopsy approaches to pancreatic cancer that one has received breakthrough FDA approval, others will soon receive some form of approval. Time will tell whether they will perform as well as they did in the trial settings. But they promise a lot. Whether they'll deliver that or not, we don't know. So these are multi-cancer panels that detect up to 50 cancers, but also have a localizing. So they give you not only the person has cancer, but patient has pancreatic. What these studies won't do is tell you where the cancer is. So they'll raise your concern for cancer without being able to prove that it's there or not there. So there are hurdles to be crossed, but I think the first step is how good are they in telling you the specificity of the.
Right.
They claim 95, 97% specificity, but you know.
Right. Okay. Thank you. Well, I think this is. I think it's too late in the day, and I would hate to keep the panelists away from the families right now. But I just thought this was a wonderful session, and thank you, Dr. Chari, for sparing time today. And it was really enlightening and a good refresher for me personally as well. And this was a wonderful talk by you. Thank you so much. And
thank you for having me.
Thank you so much, Roop, for joining in. And on a Sunday evening, it's too late.
Thank you so much.
Yes.
Thank you. Well, thank you, Dr. Maido, for again teaching us more about endotherapy. And it's wonderful having you on board. And Dr. Suresh. So everyone, thank you so much for joining in. It was a wonderful, very interactive session. We had a lot of questions and answers. What I'll do is I'll try my best to get them answered. I'll probably shoot them across to the different panelists and let them answer them at their free time. We'll email those replies to you guys. So thank you for joining in. We do have a next webinar in the series, which will be on refractory GERD by Dr. Philip Katz from Weill Cornell, who's an authority in this disease as well. This is going to be on the 26th of May. It's a weekday at 6 p.m. So further after that, we'll have it on Sundays, probably easier for everyone to log in. So thank you so much for coming in, tuning in. It was great having all of you. Thank you. Thank you.
Thank you. Good night.
Thank you.
Take care. Yeah. Have a good night.
Thank you, everybody.
Yeah.
Good night. Good to see you all.
Thank you. Bye.
Yeah.
Bye.
Yeah.
Thank you. Bye-bye.
Good night, Roop, sir.
Yeah. Good night. Good night. Take care.
Yes, sir.